This week on the Back Table Podcast.
Then Thierry de Baer came out with a nice paper that if you ablate 4 times the volume of the tumor, you really, you have low local recurrence rates. But again, it's like, well, no duh, because you're treating so much, right?
6 centimeter ablation zone.
Yeah, and just recently, last year, there was a cryoablation paper saying that if you double the short axis or the area then you got lower recurrence rates, right? So these are things important, but I think some of the stuff really came out of the radiation oncology literature where they looked at tumors on CT, and then they looked at the path when it got resected. And on average, microscopic extension that you can't see on CT for adenocarcinomas was 8 millimeters, and for squamous it was 6 millimeters. So there you have to be, when you're going to deal with a primary lung cancer, whether it's multifocal or first time, you have to be a little bit more liberal with your margins and not just go after the hard margins you see on CT.
Welcome to the Back Table Lung Cancer Weekend. I'm Scott Genshaft. I'm an interventional radiologist at UCLA.
Hi, everyone. My name's Scott O. I'm an interventional pulmonologist, also Scott, and I practice at USC in Los Angeles.
Hi, everybody. I'm Rob Sue. I'm at UCLA Health. I'm a thoracic interventional radiologist. And I trained that Scott.
Mostly in golf.
I'm Alan Lee. I'm a radiation oncologist at UCLA. I specialize in brachytherapy and thoracic cancers.
Awesome. And I'm Kavi Krishnasamy. I'm an interventional radiologist at UAB. It's a lot of fun to be here with this, the group that we have here talking about local regional therapies, everything from biopsy to curative intent therapy or therapeutic options in these patients with primary lung cancer. So welcome, everybody. Again, thank you. Why don't we get started? Alan, I'm going to put you on the spot first. A lot of options that you have in the lung. Can you talk to us a little bit about photon versus proton? And please correct me if I'm incorrect with my terminology, please.
Sure. Yeah, I mean, without going too far into the physics of it, essentially they're different particles, right? A photon's a particle and a wave, and a proton is a large particle. But the basis is that protons have the ability to, quote unquote, stop at the backside of a tumor. What they don't say is that you need to have multiple entrance arcs to get to the coverage of the tumor, whereas photons, they tend to have more of a spillage beyond the tumor, but you're using 2 different modalities to deliver radiation to the same target. The proton machines are usually much larger and much more expensive, so they're actually more difficult to retrofit. So for example, if you wanted to have more advanced onboard imaging, next generation imaging, or you want it to go faster, meaning deliver or do the imaging faster, that it's easier to retrofit a photon delivering machine because it's smaller than it would be a proton machine. Also, so far, almost all the studies across all body sites have not shown a significant benefit for using protons over photons. We still do it for pediatric patients a lot because there's a theoretical benefit of reducing low amounts of radiation going to larger parts of the body, which protons do well. But in terms of other cancers that are targetable with photons, that's usually the preference. In full disclosure, we don't have protons at UCLA, but we were looking into building one. But with all the data suggesting that it might not actually be better, we're still sort of in talks about what we're doing about that.
So when we talk traditionally about SBRT and EBRT, that's more focused on photon.
Correct. Yeah. EBRT technically would include protons, external beam radiation therapy, and they're all beams. But typically we talk about them separately. And then most places that you would go to get radiation would be via EBRT with photons, right? Which includes SBRT. SBRT is technically a billing term. It has to do with targeting, immobilization, and the dose that you're giving. But really it's if it's 5 fractions or 5 treatments or less, but not 1, then it'd be SBRT. 1 would technically be billed as SRS. And then anything more than 5, we would use another acronym. So IMRT or, hypofractionated EBRT and things like that. But it wouldn't be billed and wouldn't be called SBRT if it goes over 5 treatments in America.
Is this mostly so we don't really understand what you're talking about?
Yeah. So a lot of it is just making it super complicated so that everyone else just sort of says, Right. And then lets us do our job.
The expense of building a proton center is like orders of magnitude, or at least multiple times beyond that of putting in a traditional.
So the traditional historical proton centers are huge. They use the cyclotron, which is multiple stories tall, and it's a whole center is built around it. So it's like $100 million, $200 million to build the whole center. Nowadays, though, now that we have technology that allows to usage of MRI magnets to accelerate the particle, it makes it so that you can make a smaller cyclotron, which can now be put into a large vault, but not a whole building. So they're called single gantry proton machines, meaning that they have one sort of pathway for the protons to be generated, channeled through, and delivered to the patient. Still a huge machine. Where before, the $100 million centers are multi-gantry. So it's one giant cyclotron producing a whole bunch of protons, and it sort of like feeds it into each individual channel for each individual patient. There's like 3 patients lined up, and then the protons are delivered to those patients based on the plan that was constructed. So yeah, very, very expensive treatment, orders of magnitude larger, because the way that you think about the simple part of the physics of radiation is that to get a particle accelerated to a speed that can ionize something, you have to have either distance or power, right? So if the particle is an electron, which is what photons are essentially being created from, versus a proton is, outrageously larger than an electron, which requires essentially either way more power or way more distance. And the distance in a cyclotron is just this large circular path. That's the shortest I can make radiation physics.
I completely understand at this point. Thank you, Alan.
Wow, I feel much more educated just even in this couple minutes. Yeah, no, thank you.
Yeah,
We should do a whole episode of this. Fascinating.
Yeah. We have a whole board exam on just radiation physics. Yeah. So
Super cool.
Your physics exam is separate than our traditional oral boards. But I recall seeing my friends who went into Rad Onc at the oral boards, which was like a nice reunion.
Yeah, for sure.
I was a little jealous of them.
Yeah.
Rob, we have a lot of percutaneous options.
Oh, could I ask one question from
please.
Alan? Sorry, I don't want to disrupt the good flow, but I think what's interesting is that you see a lot of hype around proton beam, right? And so what do you tell the patient that's actually comes saying, hey, I'm looking for a proton beam and I want this because I think it's the latest and greatest? I mean, how do you advise the patient?
I basically go through the first part. What I said before is just that it depends on how old the machine is, what sort of onboard imaging it has. There's different proton technologies also, like pencil beam scanning and different things like that. So if they really want protons, which we don't have at UCLA, I would send them to the closest center that has a good machine, and if that's what they want, that's what they can have.
Right.
There's a decent chance that the physician at the proton center who sees them will say, you're welcome to come to wherever for 6 weeks to get your radiation. Your insurance might not pay for it. And you have to move here, right, for however much time.
Right.
Where I'm pretty sure that the radiation you would get at any other center would be as good, if not, maybe better in some ways. So I don't push too hard against, the patient. If that's what they really want, I put the referral in, they do a video consult. They can hear it from the proton physician's mouth and then make their decision then.
With these smaller size and less expense facilities, are you seeing across the nation more centers putting in proton option?
Yeah. So as they get smaller and cheaper, right, people start to build them more and more. So there's a bunch of centers that are buying them. There's a bunch of device companies that are making them as well. So it's become a whole thing. Yeah. And I think it's worth doing, right? Because the biggest thing is that a machine can be very expensive, but it has to be paid for somehow, right? So if insurance is saying they're not going to pay for it, you're not going to charge the patient out of pocket for that sort of thing, right? So there has to be a way to pay for the machine that you're buying, and you want to make sure that it's actually better than existing technology, right? It can't be worse than what you have and
more expensive.
Yeah, absolutely. I mean, we see that as there's advancement in ablation technology as well. That is the minimum, is that it as at least as effective as existing technology.
Also is that like for lung cancer, protons maybe is not, the greatest thing, but like for head and neck cancer, it's been shown to be helpful in certain circumstances, pediatric patients. So when they buy a proton machine, they have to figure out, the cost analysis, right, for how many patients they can treat and so on and so forth. For the really big centers, they're treating until 11 p.m. midnight sometimes, just to try to break even the cost of having the center. And they took on lots of debt to buy the machine. So there's, as it's mostly about dollars and cents a lot of the times with these things. But
with regard to the lungs, are you saying it maybe is not as effective, protons, that is? What is the reason? Is it because of the motion in the lungs that the tracking technology is not up to date, or is it something else? Because from my perspective, as an interventional radiologist, when I'm thinking about a patient that might either have local therapy with ablation or with radiation, and one of the things I'm thinking about is that scar and the inflammation that's associated with radiation. So it would be enticing to have a radiation treatment option that limited the field effect of radiation dose to the lungs. So could you comment on that?
Yeah, so I think I'm trying to use words to paint a picture, right? But like if you have to treat the whole target, to get the radiation there, you have to come in from the front or from the back or from different directions, right? Like spokes on a tire, spotlights on the stage. If you have no dose going on the backside, you still need dose coming in from the front side. So there's still going to be dose deposited sort of between the gantry head and the tumor in the direction that you're trying to deliver the radiation to. And for photons, it's very similar. So the amount of normal lung being irradiated might be slightly less with protons. It's possible. But if that matters clinically, it's not as clear. And then also with the newer photon machines, you can have better tracking in some regards. So maybe you can actually reduce the amount of target volume that you're trying to even shoot at, which would then reduce the lung volume. So it's a little bit more nuanced. I mean, if you gave me a really cheap proton machine that costs as much as a photon machine and then use the same imaging modalities that we currently have on our photon machines, then yeah, you can make really good plans with protons. But right now all those things aren't quite in place. Yeah.
Great synopsis. That was hugely educational because at least for me. Rob, you have been in this space for a long time. You've known the technology for a long time. You have published a lot in this space. Would you walk us, some of us, the novices at the table in IR, some of the ablation technologies that are out there that you like to use and have really pioneered for the rest of us?
So I think in general, historically, there have been three energies or thermal energies that have been used. It all started with a radio frequency or RF energy, which is basically imparting an electric current through the body, as you know. And then later, or I guess maybe concurrent, there was always cryoablation, but our ability to freeze tumors was limited by the devices. And I think at UCLA, we started to do cryo in 2005, 2006, when the machines just got better and the probes got better. And then we've been using it ever since. And then somewhere around 2004, something around there, microwave started to hit the market with what was called the Vivant system, which was later purchased. But that's when we first started to see some of the power of microwave energy. And then in about 2010, there were a number of new generation of microwave machines that hit the market. And so for me as a user, at that point, it was really hard to kind of triage what am I going to use, what energy am I going to use for what tumors am I going to treat and where in the lung. And so at that point, I kind of made a decision, in order for me to understand microwave energy better, I'm going to maybe not do so much RF because they're both heat-based techniques. And there are some limitations that we started to notice with RF energy. And so really the practice since about 2011 for me has been primarily microwave and cryoablation. Now, that doesn't mean that radio frequency is not a valid energy. And I think those who have had difficulty with microwave because it has a lot of power and unpredictability in some cases, such as our counterparts in Europe, for example, and Asia, they've really fallen back to radio frequency energy just because, again, user comfort, familiarity, maybe better predictability. And
cost and availability as well, right?
Absolutely. And so some places like in South America, they don't have microwave just because of cost issues. And so those are kind of primarily the energies that we use. More recently, and it's always been kind of around for a while too, is electroporation. And more recently, kind of this sort of new age of antigen preserving technology, as with high frequency ultrasound and also kind of direct current energies or electrical energy being imparted, which is now called pulsed electric fields.
Got it. Okay.
I had a question about how much smaller are they trying to make the probes, or is there like a limitation to that, right? Because I feel like the probes are kind of large compared to a brachytherapy needle that we would put in.
Again, I work in the lung space, right, where a lot of operators feel uncomfortable putting in larger needles, especially once you start getting over 15 gauge. But with that being said, eventually you either have to accept what's out there to do the case, right? So that's why even with cryoablation, I think we started using 13 gauge and 14 gauge probes, because that's what it took to make a reasonable size ice, rather than putting a number of 17 gauge applicators into the space, right? And then, so you trade off a bigger puncture hole versus a lot more punctures, right? To create that same effect. And so I think all of us want something smaller, but well, see, this is the thing. When somebody says there's a trade-off, right, it's never good, right? Because you're always doing something for something else's sake, right? And so I think we would all like a smaller gauge probe for whatever technology we're trying to use, but the problem is that, well, you may have to put more of them because you have to be able to create the size that you want in terms of ablation treatment size. And so either you just put up with the bigger probes, or you have to put a number of smaller ones. And so, again, I think companies will evolve and do this. One thing that I noticed probably about 5 years ago, and I was talking to a vendor, and they were going over cryoprobe sales. And in the United States, there's a much higher percentage of large gauge probes being sold than in Europe, which they favored the smaller gauge probes. And so here, I think in the United States, we like to do things maybe big. You know what I mean? Like just put in a big probe, get the big eyes, be done, and right? Whereas in Europe, they tend to maybe finesse more and put in more smaller probes, but they like to box and bracket tumors a lot more.
Yeah, I think the question really comes into when you talk about probe size is like, what is your concern? This is what I always ask my colleagues, because certainly there's probes on the market. Now for microwave, they're also 13 gauge. And I think most people are concerned about in the lung, bleeding and pneumothorax. And yes, probably with larger probe size comes increased risk of pneumothorax. Bleeding, I think maybe a little less likelihood. Probably the biggest issue with the probe size in general is that if it has a larger diameter, actually penetrating and getting within small tumors can be challenging, because it's just like if you're, drinking a martini, you've had a few and you're trying to kind of get the olive at the bottom. It's much easier with a toothpick than with a big straw or something of that nature.
But I will say also, one of the reasons I use a bigger, there's a 17 gauge microwave probe on the market. I actually don't use it sometimes in lung, but you lose steerability, you lose torqueability, and it's hard to target lesions. So I err on the side of bigger probes. With cryo, I'll put in multiple 17s as well. And it's not infrequent that I drop the lung to treat a lesion to protect another structure. So, and I'm very successful at putting in a tube, sealing the pneumo and getting the patient out the next morning with the overnight type observation. So I don't even view the pneumothorax risk as really an adverse event. It's more as, just it happens and we can deal with it.
Well, I'd just make a comment on that. So, as you know, there's multiple ways of treating tumors in the lung. One of which you may have heard of is called surgical resection. Now, I'm not sure if any of you have actually looked at a chest x-ray after a surgical resection. I think Dr. O probably has. But guess what? There's always 1 to usually 3 very large chest tubes in the pleural space after the surgical resection. Do you know the reason for that? The reason for that is because they have a pneumothorax. It's just being treated and probably some bleeding as well. And so from my standpoint as an interventional radiologist doing numerous lung interventions, I believe that a simple pneumothorax following intervention, whether it's biopsy or ablation or anything else, is not an adverse event. It is an event. It is an expected event. It's not a preventable event, and it just has to be managed. Now, long ago, Rob and I, when I was but his resident, we figured out how to seal these bronchopleural fistulas. So I'm not sure about you at this point, but in all these years, I've been in practice now, 13, 14 years, I've not once sent a patient to surgery to have a BPF sealed.
I think you guys bring up some really nice points because, first of all, I think if you look at ablation in general, probably the number one risk factor for complications is the number of probes that you use, right? So whether that could be in the context of treating a big lesion with multiple probes or treating too many lesions at one sitting, meaning that, you're treating 3 tumors and that makes you put in X amount of probes. So the cutoff that most papers have shown is that when you have 1 to 2 probes, you have far less complications than if you have 3 to 4 probes or more. So I always kind of, in our outpatient world, I always think about, I'm not one who's going to treat multiple lesions, especially if it involves putting multiple probes and getting over that 3 to 4 number in general, right? So then how do you reduce that risk, right? So, you can do smaller procedures, or even if they have multiple nodules, you don't go for them all in one setting, or you try to triage them. And then the other thing is what we found is this whole basis of cauterizing the tract. And I think, for historically, everybody would sort of be, don't cauterize the tract because you're going to burn a hole in the lung and especially the visceral pleura, and that's going to lead to a prolonged air leak and bronchopleural fistula. Well, I think there's a couple things to clear up. Is that, one, cauterization is not the same cauterization that people kind of think about in the OR, where you're using a Bovie and it's reaching 1200 degrees Celsius temperature. So we're talking about 90 to 100 degrees Celsius at the most, and not in a prolonged or protracted way. The goal here is to just thermocoagulate the tract, especially the subpleural lung and the visceral pleura. And in a paper that we published just last year on cryoablation and cautery, we found that if you're using any amount of probes, if you cauterize the tract, you decrease the incidence of pleural effusion. And there was a trend to decreasing hemothoraces related to cryoablation. And if you use 3 or 4 probes, then we also saw there was a decrease in the pneumothorax rate in general, but also more importantly, the number of chest tubes or the incidence of chest tubes that we placed. And so again, I think people should be doing it more because it does help sort of close that tract.
I want to come back to the bronchopleural fistula conversation because I think that there's a couple of deeper points to get into there. But I want to turn it over to you, Scott. Bronchoscopically, probably it's been, 2015, 16 with where endobronchial microwave probes kind of came to the market, and I haven't followed closely, but, tell us endobronchially, what do you offer your patients?
I think it's much earlier as far as data generation from a bronchoscopic approach versus percutaneous. So we're relatively early. The challenge with the bronchoscopic approach, the analogy I use is, instead of writing on a piece of paper with your hand holding the pen, you're holding pliers, which then are holding the pen, which then you're trying to write with. That's the challenge with doing bronchoscopic placement of a catheter of any sort, is it's not your own hands controlling the tool, it's using another catheter to guide yet another catheter. And so the manual placement of catheters has always been less than ideal. And that's actually, I think, been challenging to place catheters correctly. And that was the initial challenge. That challenge has been improved significantly of late with the robotically assisted bronchoscopy platforms. So we're able to keep it more stable, get it to where we want, get further in the lung, be more precise. So it's kind of helped that ability to get the catheters positioned where we want to get them positioned. So now we're at that phase where we can do that. So now we've just started to really place catheters and treat. So initially you think of, you deliver energy in the lung, you deliver energy in the lung. Who cares if you're going from inside out or outside in? What difference does it make? But it actually makes a big difference. And the reason why is the anatomic approach has, I think, a different anatomic implications. The bronchovascular bundle is along the airways. When you go from a percutaneous approach, you're just kind of traversing the tissue with the larger vessels being deeper. And microwave energy, of course, gets thrown back. So as you treat something, the energy gets thrown back, and it's treating smaller vessels and smaller airways as you go more peripheral. Whereas with the bronchoscopic approach, you place your catheter, and the energy is getting thrown back towards the mediastinum, which are where the larger vessels and the larger. So it has, I think, completely different implications. The other thing is, when you bleed from a percutaneous approach and you bleed into the parenchyma, it kind of is, in a lot of ways, more frequently self-limited bleeding because you're bleeding into these alveolar spaces. Whereas if you have a hole into an airway, you can bleed and it gets kind of spread through the airways if there's an event. So I think there are a lot of differences that I think maybe are underappreciated in general. So we're relatively early in that process. There were some microwave ablation studies that had not great outcomes, which made everyone pause. Now everyone has done more ablations, particularly in Asia and Europe, with a longer track record of safety now. So I think we're starting to get a little more traction in having commercially available products to be used clinically outside of pre-approved investigational device exemption status type studies, but as clinical use. So we're just starting to gain traction in that. The two energies that I think are furthest along are microwave and electroporation are probably the two furthest along, but still relatively early and still a lot to learn about how to do it efficaciously as well as safely.
How big is the needle for your working channel for the microwave?
Yeah, that's an interesting point.
Yeah.
A lot of the tools are being developed to fit down a 2.0 working channel, 2.0 millimeter. So they're tiny treatment needles and tiny cryoprobes, microwave probes, RFA probes, et cetera.
Is that limiting the size of the ablation compared to what we are using?
Yeah, so I think there's two things. It's the size and also the shape, right? Is your ablation volume a sphere, an oval, and how is the catheter placed within the lesion? What's the shape of the lesion? Do you have to bracket, not bracket? How easy is it to bracket? I think to me, some of the questions I have about delivering therapy is maybe emphysematous lung is different than fibrotic lung, is different than normal lung, is different than lung now that has a little bit of bleeding in it. The energy absorption and distribution may be different. Air obviously is a different insulating kind of state than having alveoli filled with blood. So what if there's a little bit of atelectasis? What if there's a little fissure in the way? Or it's there's, I think, a lot of things in my mind that has to be sorted out from a bronchoscopic approach and maybe shared with percutaneous as well, of how do you know intraprocedurally whether you delivered the right dose? And is it intraprocedural imaging? Do you not really know until you get the follow-up scans? How do you know you got it all, if you will, like intraprocedurally? And we're taking a lot of, cues from the work that the RIR colleagues have done in how to sort that out, I think. But I think that is still a big question in my mind of, is the dose effect so predictable you don't need intraprocedural confirmation because the catheter is so predictable in what it's going to do? Or do you need some sort of intraprocedural confirmation?
I would argue that even in IR, that's still a data gap. And in my mind, whether it's liver, lung, kidney, I have my pet peeves, as I'm sure we all do. And one of my pet peeves is just relying on the manufacturer's chart. you're never going to get what the manufacturer says you're going to get, because that's ex vivo data at 37 degrees or 25 degrees or whatever. It doesn't work, right? So I think, again, data gap, right? Great point. You were going to say something. Sorry.
I was wondering, Scott, what areas in the lung or airways in particular do you see as being prime for a bronchoscopic approach compared to existing treatment modalities?
So I guess the question it goes back, I think, fundamentally, what's going to be best patient care? And what's ideal for a percutaneous approach? What's ideal for a bronchoscopic approach? What can be done either way? And I think, in my mind, a lot of it is going to be dependent on local expertise. If you go to UCLA, you guys do all the ablations. You guys have a ton of experience. There aren't very many interventional radiology centers like you guys around the world, right? Around the U.S.
Definitely around the U.S. It's we talked about it earlier, Scott, right? It is not uncommon to go to an academic center and have the IRs not involved in thoracic oncology care at all.
Right.
Which saddens me, but that does happen, unlike liver. So
I think that's going to be one. But let's say you have the best of the best of equipment, physicians, expertise. And in that situation, I don't know yet, because I think it's too early from a bronchoscopic approach to know how safe and how efficacious it is. And without that data, I don't know what's the best approach yet. I think for me, the bigger question to ask in my mind is, who is the right candidate for non-surgical, non-radiation treatment? And I think that's a bigger question to ask, I think, regardless of is a bronchoscopic or percutaneous approach. I think that's the bigger question to ask for me. And then the other thing is also the whole question of overdiagnosis, overtreatment, lead time bias, all those things that come into play. And, that whole question, I feel like is the bigger question in my mind. And the other thing is, when you go back to that original question of what's ideal, I think central lesions are just more tricky to treat with either approach, just because there's more critical structures nearby and larger vessels. So I think the right kind of ablation lesions are just relatively easier to treat. More peripheral type lesions are just the safer, easier lesions to treat for either approach. And the more central ones are the ones that give you a bit more pause and hesitation of, should we try and ablate this thing at all?
It's interesting. I'm happy you mentioned this decision-making question of who is optimal for having an ablation or having radiation or having surgery. And I know we don't have our surgeon here right now, but you follow these patients in a little different fashion than Alan and Rob and Kavi and I. We follow our patients routinely, getting serial imaging at specific time points to look at cancer follow-up, but you're following their functional status. Could you go into a little bit of depth on how you derive some of these decisions?
It's interesting. I think surgery, because it is still, I think, the standard, and I think that's the bar that we should compare other local treatments. I'm in the world of early stage lung cancer, curative intent type treatment, that for that world, that surgery is still, the standard that we should measure ourselves. That being said, if you look at some of the more recent surgical literature, Al-Turki's paper, the CalGB study, for stage 1A, and I believe in that study was specifically 1A2 and smaller, so it was 2 centimeters and smaller lesions, for comparing sublobar to lobar resection, the landmark study published that says, you can probably do sublobar resection and it's non-inferior to lobectomy. The rate of having another lung cancer, whether it's a new primary or a recurrence, always kind of questionable in those situations, is 30%. I think we often forget that, and we expect ablation to have 90% efficacy. I don't think that's realistic. I think if we're going to treat the same type of cancer biology that was enrolled in the studies, and we're in that world, right? I'm not talking about sublobar resection for pure GGOs that are low grade, et cetera, but the type of lung cancers that are a bit more aggressive that were treated in the surgical literature, that we should expect local recurrence rates to be about 30%, or Whether it's a new primary or recurrence, you can debate, but that should be the standard, right? I think that's one thing to keep in mind. And maybe the rates will be lower because, frankly, if the types of cases that are referred for ablation tend to be the slower growing subsolid lesions, those are the type of lesions you do nothing and you do a follow-up scan in 1 year, and by RECIST, they're stable, because they haven't shown that growth of 20%, right? So I think a lot of the data that we interpret has to be interpreted in the type of lesions that are enrolled in those studies to kind of look at efficacy and safety in that patient population. So I think this is a long-winded, answer to your question of, what lesions are the best. It's when we try to get to the science and the data to compare one technology to another, I think we really have to level set with the tumor biology and the expected natural history of that type of tumor biology to begin with before we can really, more accurately compare one technology versus another.
Yeah, I think it's interesting is one of the things that arose in one of the other sessions today is just this concept that patients with lung cancer are living longer. This includes patients with localized disease, early stage lung cancer, and patients with metastatic disease. And I think that the paradigm for how we manage these patients and the outcomes that we're addressing has also changed. So for an early stage ground glass nodule, it is not simply enough to ask the question, will that patient be alive in 5 years and will they be cancer free? The question that really needs to be asked is, will that patient be alive and healthy enough in 15 years to get their metachronous primary lung cancer treated should they develop it? And that really, I think, drives some of these non-operative decisions in a certain patient population.
Yeah, I think because that recurrence rate is so high, right? We're like a lung-sparing approach in trying to preserve lung function to keep as much options on the table for treatment down the line for, instead of, in the next 3 to 5 years, much longer time. I think that's real. I think as we find more cancers, more low-grade cancers in younger patients, that's a patient population that's different. And I think what we're realizing is we used to just say, non-small cell or small cell, squam or adeno. And that was it. And then we'd argue about cisplatin versus carboplatin. That was the length of the discussion. Now it's much more nuanced. We're learning that we need to split up early stage lung cancers into much more biologically relevant subcategories to really figure out which patients are the good ones to ablate. And, I just had a patient coming up and in my clinic this coming week where it was a ground glass lesion, grew a tiny bit over a year. And you can argue, did it grow? Was it technique difference between the scans? Like that level of growth, quote unquote. And you have that conversation with them. Look, this is most likely something in the adenocarcinoma spectrum. It's probably not invasive, but small chance it is, probably not. There's a good chance you will die with this and not because of this. Do you even want to know what it is? Should we even biopsy it? Because if we biopsy it and it says something like low-grade adenocarcinoma, it's hard to sit there and watch it. And so I think in that situation, we have to start thinking about, all right, we diagnose this. Is surgery really the right option for this when we questioned even the need to biopsy it? In those situations, I feel like the best treatment may be no treatment. Or if we're going to pursue a treatment, boy, it better sure be safe. Yeah. I think the safety may be even more important than the efficacy, because the efficacy is going to be great because these are less aggressive tumors to begin with in general. They're going to have largely good outcomes. So we better make sure that whatever catheter-based ablation treatment or SBRT we offer is super duper safe in that patient population when you get into that category of should we even diagnose and treat at all?
Alan, and speaking about these patients, like these really indolent, non-aggressive lung cancers, when you're forming a treatment plan, are you thinking about that a little differently? Are you cutting the margins a little tighter, or a 1 centimeter cancer, but aggressive versus non-aggressive in appearance? What's going through your mind?
The main thing is that I know what prescription dose I have to give to have a local control across any type of cancer in the lung to a certain percentage. I don't think I would cut back the dose, mostly because, like Scott O was alluding to, is that the safety of radiation is It's pretty good in the lung. So I wouldn't cut back the dose, because what would be the purpose? It would be to potentially increase safety, which is already quite good. What I do look at, though, is that we do have limitations in how we deliver radiation. So, for example, if it's pure ground glass and very faint, you've seen the ones where you have to like squint real hard to even see it on your 1 millimeter slices. Those are actually very hard to see and track on our cone beam CT on our treatment machine. So occasionally we'll have a fiduciary marker placed in order to allow us to see it and track during treatment. So that's one limitation of treating these GGOs. But in terms of the dose, we don't really change that at all. If it's like right up against the chest wall, occasionally we'll think about rib toxicity and things like that. Or if it's really close to the mediastinum, we will think about causing some sort of toxicity in that regard. In the older studies, like the original studies for lung SBRT, local control, which was defined as growth and then biopsy proven recurrence or persistence of disease, was about 92% control in the treatment area. And then there was fatal toxicities in those trials. And that's because we weren't sure what dose to give the closer you got to large vessels and large airways. And so, now we're much better at both delivering radiation efficaciously, but also at doing it more safely, right? We do it in more fractions. If I have anything close to the mediastinum or a large airway or a large vessel, I usually end up doing it in 15 treatments, which biologically is a possibly less efficacious dose for tumor control, but it's a much safer dose to give near those structures.
I'm going to put you a little bit on the spot here.
Sure.
The 90+% local control rate.
Sure, yeah.
It's all dependent on definitions.
Sure, yeah.
Right?
Mm-hmm.
Because if you use RECIST criteria,
yeah, which you don't.
You don't.
Yeah.
So it's basically clinical judgment, right? Based on radiographic findings and and local growth, PET scan. But
yeah,
I know of 2 radiate and resection studies.
Yeah.
Where the viable tumor rate after radiation is 50% plus.
In SBRT.
In post-radiation, one was during COVID. So people during COVID couldn't get their surgery, so they got radiated. Yeah. And then later on, they're like, look, we can do surgery now. Do you want to get your lung cancer cut out? And they say yes. They get it cut out. Then they look at tumor viability within the radiated field. Yeah. And there was, about 50% of cases that had viable cancer cells in there.
Yeah.
So I don't know it. Obviously a lot more about radiation physics and the biologic effects and how long it takes and things of that nature to see the cellular effects. But how much of that local control rate is true local control versus patients die of other diseases, or because you've done a cytoreduction and it's going to take quite a while for those tumor cells to manifest as growth on a CT scan that becomes detectable. I'm not discounting the fact that who cares as long as the patient doesn't die of their cancer. Appreciate that clinical aspect of it.
Yeah.
But to say that a sublobar resection lobectomy has for 1A2 disease has kind of cancers that pop up in 30% of the patient population, it's hard for me to believe that radiation is that much better than surgery. And I know this is a hot debate.
Yeah.
Right?
Yeah.
And I don't want to be sitting in the between.
And the reason why I'm bringing this up is because I think it's a discussion that we should honestly have.
Yeah.
And I completely appreciate that it may not matter clinically. As long as the patient doesn't die of their lung cancer, who cares, right?
Yeah, so I think there's definitely a component of, bias in terms of if the patients die of something else. Like, for example, the population of patients that are in those early trials are sick patients, right? They're inoperable patients. And their overall survival from other causes of death is actually quite bad, right? Because they have either really bad COPD or really bad heart, right? Or they're like, very old and very frail. So those patients might die of something else first. When I talk about local control, which is having to write protocols for this and guidelines for this, it's challenging, right? Like how you define it. So yeah, you're right. A lot of it is sort of our clinical judgment, when it grows this type of way, in this certain direction, in this certain shape, then we get a PET. What I have in my local control is the number of patients that fail within the treatment target, right? And they get a PET, and then the biopsy shows positive disease. And that's exceedingly rare. Whether that's rare because they're dying of something else or being lost to follow-up, right? That's a very, a much more involved topic. When I say local control, I mean within field. Within the target, I actually prescribe dose to. And then if it fails on CT in a certain criteria, that's again kind of made up, and then you do a PET scan and then you do a biopsy and it's positive, that's a failure to me. There is a component of intralobar failure though, right? So there's failure right next to the target, which I talk to all my patients about, right? I tell them there's an intralobar failure, there's a regional failure, there's a distant failure, and then there's you dying of other causes, which, irrespective of the cancer. So when it comes to local control, I tell them very specifically, it's not going to come back where I shoot this, right? If it's an easy target in the periphery. As we get closer to mediastinum, I do 15 fractions, there is a failure rate. And I bring it up that way because I don't know the study that you mentioned, but if you look at the large studies for chemo-RT, for instance, like 60 gray and 30 fractions, which is biologically probably half as strong as SBRT would be, maybe less than half, that in those series, the local failure rate is probably, 50 to 70%. Yeah, right. And that's important to know, but also on the same lines of what you were talking about is that they usually die of metastatic disease, right? If they're going to die of their cancer. So if a patient has, a 3B lung cancer and we treat with chemo-RT, it's not that big of a deal if they recur locally, because if they recur locally, they probably already have recurred distantly. So now we're even in a smaller subset of patients that fail chemo-RT and don't fail anywhere else. And now we're stuck with a local failure. And as a radiation oncologist, I'm kicking myself. Why didn't I give more dose? Well, the problem is that there's a seminal paper that showed that giving more dose is actually not better. So now we have this guideline that says we can't go above this certain dose because it's bad for patients. But we know that this dose is not enough to prove local control. So we're kind of caught in this weird middle ground. And a lot of research is done now. Well, maybe if we boost focally, maybe if we do some fancier techniques. So even at radiation conferences, when we're talking to other radiation specialists about lung cancer, I would say most of the physicians I talk to that treat lung cancer, they will give the tumor a higher dose in the same number of fractions. So like we do 30 treatments, that's the prescription. And they don't want you to go over a certain number of gray, which is the prescription. So we give something in between the two numbers in that trial, and we give it just to the target, hoping that we can overcome whatever radiobiology that's making it fail at 50 to 70%. But SBRT, when I say failure, it's very uncommon. The dose we're giving is an extreme amount of radiation. Yeah, very few patients will fail. If they fail, I can think of in my practice, maybe 2 patients that have failed, and maybe 3 patients. And of those 3, two of them were on Tagrisso. So I even think that there's a component, trying to think of how much of the radiation biology to get into, but there's different phases of the cell cycle, right, which are more or less sensitive to radiation. So one of the tenets of radiation is that if you give a cell time, a tumor time, it'll go into different phases of the cell cycle, and then you hit it, cell cycle goes through again, you hit it again, and you're killing them in non-radio-resistant phases. I suspect that when you give something a oncostatic drug, right, that stops it from dividing, that it gets stuck in a certain phase. So you kill off all the radio-sensitive cells, but the radio-resistant ones are sort of just hanging out. That's what I think. Based on just my experience with that, I don't get failures unless they're on these certain medications.
When you do get a failure after providing definitive SBRT, and the patient is free from metastatic disease, it's local failure, what are your treatment options? Can you re-radiate? Do you look for another option?
Yeah, no, so that doesn't happen very often. But when it does happen, it's almost like a medical event. And maybe not to everyone else, but to myself, right? Because either that I didn't give enough dose, or we didn't deliver to the right area for whatever reason. Not in my practice, but definitely in other practices, sometimes the cone beam is not very good, right? And maybe the target's really small, and the target's a little bit off. And it's possible that one of your 5 fractions maybe was off target even, so you didn't give the full dose. But anyway, so if it does fail, and I reviewed all the information, and it was spot on, everything looks great, then I would have to present them at tumor board and try to figure out what they have done. So surgery, if they can get it, probably can't, because why would they be getting radiation to begin with?
Right.
And then if they can't get surgery, then I usually will send them to you guys, to IR, to see if there's an ablation technique that might work. If that doesn't work, then we've historically been treating patients with percutaneous brachytherapy, which is, you guys know well. Yeah, so.
Yeah, I think, a couple things is that, I think Brooks had a nice paper, I think in 2018 on radiation recurrences and what to do after that, right? So a good number of them did go to surgery. Many of them were re-radiated too successfully. But I think, we're trying to balance dose, whether it's radiation or ablation, and we want to minimize what we're trying to do and create damage and reduce complications, but we want to be mindful of treating the tumor well enough. And I think, one thing, at least for ablationists, is that what you see on CT scan is not necessarily all of the tumor. Sure. Right. Mm-hmm. And there was some really
That's
nice
the whole concept of margin.
Right.
Absolutely.
And so, I think in 2004, there was a paper by Lee that said, okay, well, if you create a 5 millimeter ablation margin, then those had better local control than if you had something under that. And everybody's been sort of sticking to that for whatever reason. Then Thierry de Beer came out with a nice paper that if you ablate 4 times the volume of the tumor, you really you have low local recurrence rates. But again, it's like, well, no duh, because you're treating so much, right?
6 centimeter ablation zone.
Yeah, and just recently, last year, there was a cryoablation paper saying that if you doubled the short axis or the area then you got lower recurrence rates, right? So these are things important, but I think some of the stuff really came out of the radiation oncology literature where they looked at tumors on CT, and then they looked at the path when it got resected. And on average, microscopic extension that you can't see on CT for adenocarcinomas was 8 millimeters, and for squamous it was 6 millimeters. So there you have to be, when you're going to deal with a primary lung cancer, whether it's multifocal or first time, you have to be a little bit more liberal with your margins and not just go after the hard margins you see on CT.
Yeah, I mean, we have explained this to our trainees, our mutual trainees, is, these lung cancers are different than metastases because they're kind of like lung. Mm-hmm. So they are growing along the lung because they're still partially lung and they're masquerading as normal tissue. And so just always go bigger. And in addition, you are going for a curative intent when treating lung cancer, whereas when we're treating oligometastatic disease to the lung, really their outcomes are going to be largely driven by the tumor biology and how it's behaving globally. So it is a difference. Now, with regard to local recurrence, we do see, I realize this is a little outside of the topic of this conversation, but there are radioresistant tumors. And so we commonly see local recurrences in the setting of metastatic disease to the lung. I'm thinking very specifically to renal cell carcinoma, that commonly it fails after radiation. Do you have any thoughts on that? And is that a technical approach, or are there just some limitations of SBRT in these settings?
Yeah, I mean, I have to look at the case specifically. Nowadays, when we do radiation to a metastasis, it's the same dose that we give to cure lung cancers. Going back a little bit, my plans for radiation, when I'm generating them, the center of the target is the GTV, the gross tumor volume, is actually getting usually 120% of my dose or higher. My prescription is 50 and 5, let's say, right? 50 gray in 5 fractions. But the actual target is going to be getting 60 gray in 5. And the GTV is actually an iterative GTV. So we do a 4-dimensional or 5-dimensional, it's 4-dimensional CT scan that allows us to see the tumor moving while they breathe. So the IGTV is actually how much and where the tumor is moving, drawn as a volume. And then we put a margin on that of 5 millimeters. So the center is getting 120, the periphery is getting 100, and then as you get further away concentrically from the target, from the PTV, from the planned target volume, the dose gets a little bit lower. But even at 1 centimeter from the tumor, 5 millimeters is getting 100, right? Another 5 after that is probably getting like 90, maybe. So, and we're talking about microscopic tiny pieces of the tumor, right, that weren't visible on imaging, which probably don't need as much dose. And I say that we know that empirically now, right? Because we've been doing it this way for, probably 15 years now. And we get very low marginal misses, right? If you think that the target has an 8 millimeter spread, then you would suspect that if I prescribe radiation this way, that you would get a lot of failures like 1 millimeter beyond that area, right? But we just don't see that very often. Yeah, I don't know if that partially answers your question.
Is there like a movement for oligometastatic disease, for example, to reduce the number of fractions?
Say that one more time.
I think what I've seen is that there's a lot of interest in reducing the number of fractions, especially in the setting of oligometastatic disease, so patients don't have to come so many times, right?
Yeah. So, well, that's the way that the field's moving in general, right? So this is a topic on its own, but basically, payment for cancers is trying to be bundled when it comes to radiation. So like they give you this much money, and then you do whatever you want to do, and then so doing it in less treatments is better, both for the patient as well as maybe for future financial topics. But the thing about reducing fractions is that if you give everything in one fraction, in one dose, then you have to make sure that you will overcome all the radiobiologically resistant cells that are stuck right now in S phase or whatever. So there is some radiobiological decrease in effectiveness, possibly, when you do less and less and less fractions. Paradoxically, is that the biologically equivalent dose, which is a calculation based on prescription dose and then based on number of fractions. So for instance, 100 gray in one fraction versus 100 gray in 100 fractions is monumentally different in effectiveness, right? So as you reduce the number of fractions and then keep the prescription the same, your biologically effective dose is actually going up. So if I do 50 and 3 versus 50 and 5, 50 and 3 is much more biologically effective.
But it sounds that you also have the issue, and perhaps I could start with the question is, when do the cells actually die after you're zapping them?
Yeah, which is a really good question. So like, are they an indolent cancer? Are they an aggressive cancer? Like, usually the more aggressive, faster dividing ones, they tend to respond differently, right? And so when you are giving radiation, you really want to make sure that you're, enacting the highest local control. And so if you do lower doses per fraction, you can overcome some of the radiobiology. If you do more doses per fraction, potentially you're catching them in more radiosensitive phases. Sorry, what was the question again?
There's two questions I have really. One, when do the cells actually die?
Oh yeah, right.
Like this.
Yeah. Sorry. Yeah, so it depends on the pathology actually. So for example, for squamous cell carcinomas, I'll use the best data that we have, but for anal cancers, that if you give chemo-RT for anal cancer, which is definitive, that at 3 months, they might still have a nodule there or a tumor there. And if you biopsy it, it will be positive for viable cells according to the pathologist. But at 1 year, it's not the case anymore. So at least for anal squamous cell carcinoma, there's something that happens between month 3 and 12 where the cells actually become pathologically appeering to be non-functional, non-viable anymore.
That answers some of the questions I had about the treat and resect type studies, because I don't think they were all 1 year or later, right? Which would explain seeing some viable cells still.
It's possible, right? Because like viable on pathology versus viable growing into a new tumor is completely different. Right. Yeah, right? Because you can have a cell that has the DNA completely damaged beyond repair, and it'll look like a viable cell, until it tries to divide.
And that goes back to actually what you said about margins. Like I've trying to design and look into ablate and resect studies. When you take a resected lung, formalin fix, paraffin embed, a lot of things happens to the tissue. It's no longer inflated, right? It becomes atelectatic. And then if this lesion is really solid, the solid component doesn't really collapse, it's just still there. But if it's a subsolid type lesion, it collapses and becomes smaller. So there are changes just in the pathologic processing of the specimen, which makes it hard to measure. All right, if you see it as 1.5 centimeters on path, how do you equate it back to what it would have measured on the CT scan when the lung was inflated? And what's the delta from that? And of course, CT scans, you have, I think, a little bit more spatial 3D. Like you have to cut it in the perfect coronal plane at the cut that you're measuring on the CT scan, and trying to correlate all that and see what the delta is on that is challenging, I think, in trying to see what your margin should be. And I think the delta, it can be also over and underestimate. And one is because you see a density on a CT scan. How much of that is cancer? How much of it is distal atelectasis? Can't tell the difference, right? And then you have those well-circumscribed, super solid lesions versus those spiculated ones with the arms. And you're like, well, what do you count as the length and what do you don't? And I think the margin, like where is the margin for that stellate lesion? The margin ends, I think, at the end of the tendril, whereas those well-circumscribed ones, the margin is probably right where you think it is on the solid. So I think that idea of margin is super important in trying to figure out. And it's really hard to predict when you ablate something where that margin is.
Well, are we at the point where we can prescribe margin based on mutational status? Do we have any information there?
I don't know of any.
I've seen some older historical studies, both surgical and ablative, where we're looking at 5 versus 10 millimeter margins, depending on the histologic subtype of the tumor, things like that. But I agree. I don't think we are there, but should we be eventually going there, right? Is margin different depending on that subtype of tumor and how, obviously, that then portends to how aggressive the tumor is, et cetera, et cetera, et cetera. But yeah, something to be answered in the future, probably.
I mean, one margin question I have a lot is the pleural retraction all the way to the pleura, right? Because I've asked a handful of surgeons about it, and I guess our surgeon's not here right now to talk about it, but I've asked a few of them, and some of them say, oh, why we don't usually see cancer in that retraction area. And some say they do. Pathologists, and some say they do, and some say they don't. So, for me, it's like when I'm like, okay, well, I'm going to treat with radiation, because some of these tags, they go out like 4 centimeters to the pleura.
Yeah.
Well, is there really cancer crawling along this pleural tag? I'm not sure. Yeah.
And you don't like that. You would like to limit the dose there because of some side effects, correct? Like to the chest wall itself and to the ribs. Could you talk about those side effects of radiation?
Yeah, so anytime you increase a linear distance away from the tumor, you have to increase the volume of treatment that you're doing. So like if you're treating a 4 centimeter linear structure, actually requires quite a lot of volume, right? Delivering radiation to it. So I put a 5 millimeter margin around it, so the volume increases exponentially. And then some side effects you would see, we usually talk about pneumonitis the most, but most pneumonitis is radiographic pneumonitis. Right, the patients don't have. You've seen these patients, right? Their scars maybe a little bit ugly looking, but they have no change in lung function. And the percentage of radiographic pneumonitis is probably nearing 100%. Like there's going to have some fibrosis or some pneumonitis from the radiation. If there isn't any, I question if I hit the right target.
Right.
Yeah, like did I treat this patient? Yeah.
Did I forget to turn it on?
Yeah, because it looks very distinctive.
Yeah.
Chest wall is another toxicity. So we usually say that the chance of getting any sort of rib fracture toxicity depends on where the tumor is and what dose you're giving. There's a controversy in single fraction SBRT for lung cancer that when I have a tumor close to the chest wall, I tend to do it in 5 treatments because I worry about rib fracture, rib toxicity. Other physicians say that there's no change in rib toxicity from doing it in 1 fraction, and so they proceed with that. I think the jury's still out on that. If you ask a whole bunch of people, everyone has a different opinion about it. But those are the 2 main toxicities when it comes to these easier lesions to treat. There's more obscure toxicities, right? So like there's like hemorrhage if you have a airway involvement and you're treating with too high of a dose and you didn't reduce the dose to the bronchus enough. There's like brachial plexus toxicities, right? Which at the very apex of the lung, it sort of drapes over that area. And if you weren't thinking about it, or maybe if the arm is positioned slightly different at a different angle, that might even change where that brachial plexus falls. So we have a structure that we use in radiation planning called a planned risk volume, a PRV. So I would draw the brachial plexus out and I'll put a margin around it, like 3 or 4 millimeters, and say no radiation to this dose can go to this area. And sometimes you're trying to thread a needle, right? You're trying to say, well, I want to give this 100%. I want to give this like 50%. So you really have to, get the plan right. Sometimes we'll talk to the therapists or people that treat the patients on the machines, be very careful of this patient, that this is a very difficult plan to construct and so on and so forth. Yeah.
How much dose can nerves take before they suffer severe damage?
Yeah, so the smaller the nerve, the less they care about the radiation, and the bigger the nerve, the more they care about radiation. So for example, if you treat the spinal cord, it's actually very radiosensitive. And for two reasons, right? One is that if they do have damage to the spinal cord, it's catastrophic, right? So it's a toxicity that we never want to see, right? So it's the TD, right? So toxicity dose, we want to be like less than 1% chance of happening, right? And that has a certain dose. And so if you have a tumor that's right up to the spinal cord, we do SBRT for that, but we have to carve off the dose where the spinal cord is to prevent, having severe damage. Brachial plexus is a slightly smaller nerve than, the spinal cord would be. And so the dose tolerance is a little bit higher, what we allow it to go to. And then sometimes we would even say like, okay, well, the tumor is here. This is a curative situation. They have no other options. What do we do? Well, I think we should talk to the patient and say, listen, I want to cure your cancer. I have to give this much dose. You have a X% chance of having this toxicity. So early type of, or lower dose radiation toxicities to the brachial plexus could be numbness, tingling. It'll maybe go away after a few months. And the most severe would obviously be motor dysfunction. But motor pathways are typically slightly more resistant to radiation deficits. So you have this, this situation where, okay, well, you might get some tingling, but we're going to cure this cancer. So that's sort of the needle we're trying to thread.
What about, Alan, like I've seen some patients with peripheral cancers that have undergone SBRT, but then they have chronic chest wall pain.
Yeah.
Right. So how is that really from the nerve damage, or is it because there's contracted tissue now sort of scarring up, along the course of the nerve and maybe causing some sort of irritation?
Yeah. For chest wall toxicity, it's lumped in our toxicity categorization, right? And it could be from any of those causes. The dose constraint we use for the chest wall is to prevent any grade of chest wall toxicity. Well, usually I say less than grade 2 is, but grade 1 is okay. A little bit of tingling here, not having to take medications, I think we're good. Grade 2 or 3, then we run into territory having to take narcotics, we're having interventions or nerve blocks. So we have a very specific dose constraint that we use to prevent anything higher than grade 1 chest wall toxicity. Why it happens, it's unclear. So sometimes I'll have a patient with what looks like their ribs are, I've seen patients that had SBRT, let's say 10 years ago, and I've been following them from other people that have retired or whatnot. And they have like a sandblasted look to their ribs. Have you seen this before too? Yeah,
of course.
Yeah, and when I see that, and then I'm like, oh, this patient is in huge trouble. We should be sending them for hyperbaric maybe. Talk to the patient, they're fine. They don't have any pain at all, right? So they have radiographic chest wall toxicity, but no clinical toxicity. And that's different because we'll have some patients that have perfect chest walls and they have horrible chest wall pain from some radiation dose that we were giving them. So to answer your question, we don't really know if it's nerve damage, if it's some sort of contraction, but we do know that osteoradionecrosis doesn't necessarily correlate one-to-one with chest wall pain. Yeah.
Why don't we stop there and pick it up after lunch?
Thank you so much for joining us on Backtable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _backtable onc. That's _backtable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Bagrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.